Soo. Kim Hun Soo là một bác sĩ rất là tài năng và hiện nay thì là đang làm ở khoa chẩn đoán hình ảnh và can thiệp của Samsung Medical Center. Đây là một chuyên gia về xương khớp và hiện nay thì là đã có rất là nhiều những cái báo cáo liên quan đến cái lĩnh vực về điều trị giảm đau cơ xương khớp và các cái bệnh lý các khối u của cơ quan vận động. Sau đây thì là xin mời báo cáo đầu tiên của bác sĩ Kim Hun Soo.
Hello, I'm Hyun-soo Kim at Samsung Medical Center in Seoul, Korea. I appreciate the committee for inviting me and offering me a chance to present this lecture. Today, I'm going to talk about spinal intervention for pain management in this disease. Before starting with the lecture, I would like to congratulate on Vietnamese people for the first victory in the third round of Asian qualifiers for the 2022 FIFA World Cup. Korean people are interested in Vietnamese national soccer team as head coach Hang-seo Park manages the team. Let me start with a brief review of anatomy of the epidural space. Epidural space is an anatomical space within the spinal canal that is located outside the dural sac. This space is continued to bilateral uroforamen. The space is outlined by posterior longitudinal ligament at the ventral aspect and ligamentum flavum at the posterior aspect. Epidural space contains fat venous plexus and lymphatic vessels and is surrounded by a thin structure called peridural membrane. This structure is continued as circumneural sheath that surrounds the epineurium of the nerve root. Dura is continued as the epineurium of the nerve root on the other hand. Corticosteroid has been used as a major pharmaceutical agent for management of pain in spinal disc disease in 1960s. Particulate agents such as methylprednisolone or triamcinolone has long been used for epidural steroid injection, but as there has been cases of embolic infarction related to intra-arterial injection during spinal intervention, these agents are recommended not to be used since 2015 by FDA. The non-particulate agent dexamethasone is thus commonly used. This agent is freely soluble in water, unlike most particulate agents. The most commonly accepted mechanism of epidural steroid injection in management of pain in spinal disc disease patients is that anti-inflammatory effect of corticosteroid prevents the action of phospholipase 2. This is an inflammatory cytokine that can be released by rupture of the disc and provokes cascade of inflammatory reactions. A number of other possible mechanisms have also been suggested. This is an example of a prepared set of agent for spinal epidural steroid injection into lumbar spine. We use dexamethasone and ropivacaine, and we use mosquito clamp to handle the needle in order to avoid radiation exposure to the hands. When evaluating patients with suspected spinal disc disease and radiculopathy resulting from it, do we really need spinal MRI before performing epidural steroid injection? Well, some may insist that in selected cases with obvious neurologic signs and definite localization of the affected spinal nerve may be possible without MRI. However, for a safety reason, I insist MRI be obtained prior to the procedure. Besides determining the site of epidural steroid injection, pre-procedural MRI is needed to make sure the patient doesn't have spinal dural AV fistula. Spinal dural AV fistula is the most common spinal vascular malformation, which is formed by abnormal communication between artery and vein feeding the spinal cord. These result in chronic venous congestion of the spinal cord. This condition can clinically mimic the presentation of spinal disc disease or coexist with the disc disease. On MRI, a tortuous and dilated perimedullary vein within the dural sac is characteristic finding. It may be subtle on sagittal MRI of lumbar spine level, so we need to pay special attention around the conus medullaris. I've encountered a number of patients who developed acute and irreversible neurologic deficits that developed right after receiving epidural steroid injection at outside hospital, and they were found to have spinal dural AB fistula. These detrimental events have been attributed to aggravated venous congestion of the spinal cord by increased epidural pressure. Thus, we should always look for possible presence of spinal dural AB fistula and never attempt epidural steroid injection in these patients. There are three routes for delivering steroid in the epidural space of the lumbar spine. The first is interlaminar approach, which targets the posterior epidural space by traversing the ligament structures located between lamina and spinous process. The second is transforaminal approach that targets posterior superior aspect of the neural foramen. The third is caudal approach, for which the needle is advanced through the sacral hiatus. According to the recent guideline by American Society of Interventional Pain Physicians based on a systematic review, all three previously mentioned approaches have been recommended to be beneficial in the management of symptoms related to disc herniation or radiculitis. Generally, we intend to deliver corticosteroid near the pain source, so transforaminal approach is usually performed in cases of unilateral radiculopathy resulting from disc herniation or spinal stenosis. In the classic supraneural approach of the transforaminal injection, target for the procedure is the perineural fat at the posterior superior aspect of the neural foramen. The fluoroscopy tube is rotated to the side of the approach, which best visualizes the typical Scotty dog appearance. There is an imaginary triangle formed by lower margin of the pedicle, lateral border of the vertebral body, and lateral border of the nerve root. We call it a safe triangle, and it is located just below the jaw of the Scotty dog. We advance the needle targeting the safe triangle in supraneural approach to avoid inadvertent injury of the nerve root. Delivering the agent along the anterior epidural space can be achieved by this approach. When the needle arrives near the neural foramen on the lateral view, you want to make sure the needle has also arrived at the lateral margin of the vertebral body on the AP view. Then a small amount of contrast agent is injected while slowly advancing the needle. You should avoid advancing far medial to the midline of the pedicle in order to avoid dural puncture. When the needle is located at the right place, you can identify it by visualizing the contrast agent extending along the nerve root and anterior epidural space. I just mentioned that the target of the supraneural approach is called a safe triangle. Yet it has been reported that radicular and radiculomedullary arteries are located at anterior superior aspect of the neural foramen. We should especially be concerned about the dominant radiculomedullary artery known as artery of Adam-Keats, located between T9 and L2 level. Alternative approach called posterolateral or retroneural approach has been suggested. And in this approach, we target area close to pars interarticularis or superior articular process and place the needle tip posterior to the nerve root. Through this approach, we can deliver drug at the posterolateral corner of the epidural space. In this approach, risk of nerve root irritation or arterial injury could be lower than those in supraneural approach. For interlaminar approach, we target the posterior epidural space where abundant fat tissue is present. The spinal needle has to traverse the ligamentum flavum to get here. Interlaminar space is bounded by spinous process and lamina, which is shown as radiolucent area on AP view. The operator should modify the craniocaudal angle of the tube to identify the view that shows maximal space to allow easier approach of the needle. The posterior epidural fat is most abundant in the midline, so generally it is advisable to advance the needle to the median portion of the interlaminar space. But in case of scoliosis, which does not allow this approach, we may approach through the paramedian area that allows the needle entry. So before planning the interlaminar injection, we should review the MRI carefully to determine whether there is enough posterior epidural fat to perform this approach. On the lateral view, we advance the needle tip. It is located around the posterior half of the facet joint. The needle tip should be around the ligamentum flavum. Then a small amount of contrast agent is injected while slowly advancing the needle. When the needle passes through the ligamentum flavum, at a certain point, we can identify contrast material spread along the posterior epidural space, which we call it a radiographic loss of resistance. In caudal approach, a structure with inverted U shape formed by sacral cornea on each side, which is called sacral hiatus, is the target for the needle advancement. It is covered by posterior sacrococcygeal membrane. The needle should enter the sacral hiatus and advance to cephalic direction in midline. The lower end of the dural sac usually is located around the level S1 or S2, so a needle should not advance further above the level of S2 lower end plate to avoid dural puncture. The extension of contrast material resembles the appearance of Christmas tree on AP view. It is necessary to check the superior extension of the contrast material to the target level. Let's move on to epidural steroid injection in the cervical spine. Interlaminar approach and transforaminal approach are used in patients with cervical disc disease. Unlike in epidural steroid injection of lumbar spine, interlaminar approach is recommended option in the cervical spine, irrespective of disease category or laterality of the symptom. The main reason for this resides in the fact that both interlaminar approach and transforaminal approach demonstrates similar clinical improvement, while there is a potential risk of developing a serious vascular complication in transforaminal injection. Posterior epidural space are quite narrow in the cervical spine, thus patient should flex his neck while in his prone position to widen this area. In addition, irrespective of the level of the diseased disc, it is recommended to perform this injection at C6-7 or C7T1 level, as the posterior epidural space are wide at this area. So the needle is targeted at the area between spinous process on AP view. The needle tip is advanced to reach the spinal-laminal line on lateral view. While slowly passing through the ligamentum flavum, radiographic loss of resistance with spread of contrast agent can be seen. As previously mentioned, interlaminar approach is recommended choice for cervical spine, but there are a number of indications for transforaminal approach. It can be performed if the results of interlaminar approach is not satisfiable, or if a single cervical nerve root compression seems to be the main cause. Cervical neuroforamen is facing anterolateral side in about 45 degrees, so patient is placed in his supine position. Since the vertebral artery is located right in front of the nerve root, we should target the posterior aspect of the neural foramen. In addition, since jugular vein and carotid artery are placed in the path for transforaminal approach, please have the patient turn his face to the opposite side. The operator should turn the tube to best visualize the neural foramen. The target should be the area just ventral to the superior articular process in order to avoid penetrating the vertebral artery. The tip of the needle should be advanced about lateral 1/3 of the lateral mass. Then a small amount of contrast agent is injected while slowly advancing the needle. The needle should not pass the median point of the lateral mass to avoid nerve root injury. When the needle is in right location, contrast material spreads along the course of the nerve. Now let me show some of the complications that may occur during the procedure. Dural puncture may occur during interlaminar approach. The contrast agent can be seen quickly moving to the dependent portion within the central canal with clear margin as this picture shows. Intrathecal steroid injection may cause aseptic meningitis, arachnoiditis, and intrathecal analgesic injection may cause severe neurologic symptoms. Intraepineural injection can happen during transforaminal approach. The patient can express severe pain during the procedure. It can be seen as a feathery appearance or as a tram track appearance. When such findings are noted, we should replace the needle to avoid possible nerve injury. One of the most dreadful complications related to cervical steroid injection is cerebellar infarction. It can result from vertebral artery injury by spinal needle. Another reported serious complication is spinal cord infarction. There are radicular or segmental medullary arteries supplying the spinal cord and cervical spine. So injury of these arteries may produce spinal cord infarction. Thank you for listening, and I would like to express my special thanks to my colleague, Professor Ji-hyun Lee, for sharing his material for this lecture.
Rất là cảm ơn bài báo cáo của